You broke it. Today, we begin the 9th in a series of hearings conducted by the Joint Fiscal Committees of the Legislature regarding the Governor's proposed budget for the fiscal year 2016-17. The hearings are conducted pursuant to the Article 7, Section 3 of the Constitution and Article 2, Section 31 and 32A of the legislative law. Today, the Assembly Ways and Means Committee and the Senate Finance Committee will hear testimony concerning the budget proposal for the mental hygiene. I will now introduce members from the Assembly, and Senator Young, chair of the State Finance Committee, will introduce members from the Senate. I have been joined by Assemblywoman Eileen Gunther, Assemblywoman Jaffe, Assemblyman McDonald, Assemblyman Miligalsis. Okay, I chewed it up again. Assemblyman Rosenthal, and Assemblyman Weprin, and Assemblyman Oaks. No, get it so it'll be right. And no, I didn't see that. And D.D. Barrett.
Yes, and Assemblywoman Malia-Takis is here, yes. Oh.
Good morning. I'm Senator Catherine Young, and I've been joined by my colleague, Senator Liz Kruger, who is ranking member on the Senate Finance Committee. We're also joined by Senator Robert Ort, who is chair of the Mental Health and Developmental Disabilities Committee, Senator Fred Akshar, Senator Gustavo Rivera, Senator Terrence Murphy, and Senator John Bonasek.
Thank you, Senator. And we're also, Assemblyman Jeff Aubrey is with us. Before introduction, though, and the first witness, I would like to remind all the witnesses testifying today to keep your statements within your allotted time limit so that everyone can be afforded the opportunity to speak. And we're going to put in a special rule today. Each commissioner will do 1 hour after they have made their presentation with members talking. So to the members, I would ask them to please stay to your 5 minutes. Chair people have the responsibility of 10 minutes. I would also remind the people who are listening to us in their rooms upstairs, don't wait for the last minute to come down and get online. We will have closed you out by that time. So to begin with, Assemblywoman Maria T. Sullivan, MD, Commissioner of the New York State Office of Mental Health.
Thank you. Good morning, Senator Young, Assemblyman Farrell, and members of the committee. And thank you for this opportunity to discuss the State Office of Mental Health Executive Budget Proposal. The 2016-17 Executive Budget continues to take significant steps to address the needs of people with mental illness in New York. The main areas of focus of the Executive Budget proposals for OMH will focus on the transition to integrated Medicaid managed care for adult and child behavioral health services, the Office of Mental Health Transformation Plan for our state and community-operated service systems, and our continuing commitment to the development of housing for individuals with mental illness. Funding for the Children's State Plan Amendment Services. The 2016-17 Executive Budget includes $7.5 million, annualizing to $30 million, to support an array of new Medicaid State Plan Amendment Services to expand the behavioral health services for individuals under 21 years of age, including crisis intervention, community psychiatric support and treatment, psychosocial rehab services, family peer support services, youth peer support services, and other licensed practitioner services. The funding of these state plan options will now allow the New York State to fill the gaps across the current children's system of care and will produce better long-term outcomes for children and their families. This children's system redesign will truly be a game changer by recognizing the broad range of supports required to prevent, intervene, and treat children with or at risk for serious emotional disturbance. Managed care transition funding. For both adults and children, the 2016-17 Medicaid budget also continues funding to support the transition of providers into a managed care environment by supporting extensive technical assistance, including development of infrastructure and capacity for the integration of children's services into mainstream plans, collaborative care to integrate behavioral and physical health, establishment of Health Home Plus for high-need populations, targeted vital access funds to preserve critical access, and expansion of cost-effective home and community-based services. We are well into the second quarter of adult integrated managed care and HARP implementation in New York City. These investments have been critical in preparing our consumers, providers, and managed plans for transition, and especially as we roll out the managed care expansion and HARP in the rest of the state in July of 2016, and for children in January 2017. The OMH Transformation Plan for State and Community Operated Services. For decades, New York State has sustained a system of mental health care for its citizens, which relied heavily on state-operated hospitals. We exceed both the national inpatient utilization rate for state psych centers as well as the per capita census levels in state psychiatric centers compared to other states. This is a costly arrangement that has prevented the investment of dollars in needed community services which can prevent the need for inpatient hospitalization. Accordingly, the 2016-17 executive budget includes full funding of the previous 2 years' reinvestment, $59 million annualized, and an additional $16.5 million annualized to support this year's reinvestment. These funds will further develop the critical community services and supports needed to prevent inpatient hospitalization and transition individuals from inpatient settings. The results so far for our community reinvestments during the last and current year have been very promising. The new and expanded services have already reached over 8,000 new individuals across the state. This includes 246 additional home and community-based waiver slots, 12 state-operated mobile integration teams, 7 of which are currently up and running, and 5 which are in development and just getting ready to get started, 16 new and expanded crisis intervention programs, new advocacy outreach and bridger programs, 5 assertive community treatment teams, and 3 new operated child and adolescent crisis respite houses. These services put us firmly on the path toward balancing our institutional resources more equitably and serving more people in clinically appropriate, effective community treatment and support programs. Housing is a cornerstone to recovery and successful community tenure for the people we serve. The 2016-17 executive budget includes $50 million to support approximately 1,200 new beds opening in 2016-17 and to cover the ongoing operational costs of 800 beds from the 2015-16 fiscal year that will be online this March. Once these are open, we will bring our bed total to over 44,000, more than any other state in the nation. As you know, the governor has announced in the State of the State an extraordinary commitment to homeless housing. The Office of Mental Health will be working very closely with the Division of Housing and Community Renewal to secure a portion of this funding for housing individuals who are both homeless and mentally ill. Finally, I would like to thank the governor, members of the advocacy community, for the enactment of legislation that allows a tax checkoff for mental health public awareness. Citizens of New York now filling out their income tax forms and e-filing will see a tax checkoff for mental health public awareness. Again, thank you for this opportunity to address you on the 2016-17 budget, which supports and continues the work we have begun to transform New York's mental health system. Thank you.
Thank you very much. The next, first question, Aileen Gunther.
Good morning, Commissioner Sullivan, and thank you for attending the meeting today. I've done a little basic math that I'm happy to share with you after the hearing. But what it looks like to me is that the $110,000 that is supposed to be reinvested in the community per bed reduction is actually $41,250. If you multiply that by 200 beds that we're losing, it comes up to over $13 million. And I don't think, I'd like to know where that money is going. And I looked through the all of our budget books, and I looked at the closures versus where the money is going, and the math doesn't add up to me.
Oh, thank you. The reinvestment dollars for this year total $16.5 million. That's what's going to be put into the reinvestment for the closure of 200 beds. Now, 100 of those beds will be getting the full reinvestment of $110,000 into community-based services, so that's approximately about $11 million. The other 100 beds are individuals who have been in our state hospital system, but who truly need nursing home care. And they really should be in a less restricted environment than a hospital, and really in a nursing home. We, in terms of transitioning our population to those nursing homes, we will need to establish with the nursing homes policies and procedures and additional staff to work with them. That staff is included in half of the reinvestment dollars. So that would be $55,000 will go towards those teams working with our 100 individuals in the nursing homes. So to be absolutely transparent, we wanted to be clear that we didn't consider that to be community-based services. So of those 100 beds, the other $55,000 does go to direct community-based services. That's about $5 million. So for the 200 beds, there is a reinvestment allocated of $16.5 million. You are correct that a portion of that, about $55,000 per 100 beds going to the nursing homes, will be for teams to work with the nursing homes. So that's the way the money is being allocated.
Now, do you have buy-in from nursing homes? Are these going to be county nursing homes or just non-for-profits?
No, not-for-profit. Whatever nursing homes are local and in the areas where our patients want to be and where their families are. So we'll be working with a variety of nursing homes across the state.
My other question is about the training. These are folks that have been in facilities for a very, very long time. And this is a geriatric community. Sometimes we talk about placement of people with disabilities in long-term care. How do we feel that this placement is appropriate for somebody with a long history of mental health that probably, I don't know whether the staffing is very specialized, to be specialized in mental health issues, anxiety disorders, and all of those kinds of things. How are we going to train the staff to give appropriate care to these aging individuals? And are they really geriatric patients, or are they young people that have just spent a lot of time in a mental health facility?
No, these are, by and large, they are aging individuals who now have considerably complex medical problems, which really can be well served in a nursing home population. And that's why we have these teams. They will not just work with the clients, they will work with the nursing homes to provide the training, just as you said, quite appropriately, for nursing home staff to be able to understand how to work with our clients. I think that often that training isn't there in the nursing homes, and that's why these teams will be very tightly wound around these individuals going to the nursing homes and doing that training.
So how is moving a person from one place to another reinvesting? Like, in other words, if you have a person moving from, as an inpatient, from a psychiatric center to a long-term facility, what is the benefit, and where's the savings, or is there savings, or what is the intention of it?
Yeah. The intention is to really provide a better setting for these individuals. We really feel that because of the medical issues that they have and the kind of care that's in a nursing home, that they would be better served clinically. That's number one. Number two, that's why we're not assigning the full community reinvestment to these beds, but we are setting up these teams to work with the clients in the nursing homes. When we also downsize these beds, it's by eliminating a bed, for example, that is occupied all year long with one person, we then open up the availability for other community-based individuals to come into the state psychiatric centers because of the turnover phenomenon, the number of admissions you can actually have. So we will be able to even better serve some of the acute needs of the communities with lesser beds, with fewer beds.
So another commitment that was made to the legislature and to the provider community was a $120 million commitment to a BHO HARP investment. Almost immediately, that commitment was reduced to $115 million. Why is that?
That was reduced as a budget accommodation, I believe, last year. So this year we have been working with the number of $115 million. That $5 million was decreased last year.
Okay, I'm going to come back again.
No, you can go. You can go to 10 minutes. Keep going.
Okay. you look at the $40 million for community service, $20 million for BHO, okay, I'm just looking, I think that's it for now.
Thank you, thank you.
Thank you, Senator. Senator, oh no, before that, I've been joined by Assemblyman Danny O'Donnell and
And we've also been joined by Assemblyman Cliff Crouch.
Senator.
We've also been joined on the Senate side by Senator Terrence Murphy, Senator Diane Savino, Senator Kathy Marchione, and Senator Tim Kennedy. And our next speaker is Senator Robert Ort.
Good morning, Commissioner. Thank you for being here. Is there any new funding for community services in the OMH budget beyond the 0.02% COLA, which by most estimates will increase the salary of a staff member who makes $50,000 annually by an estimated $100 annually, or about $1.50 per week after taxes?
No, that's the amount that is in the current budget. Last year, there was a COLA of 2% for 4% for direct care workers, cumulative, and 2% for clinical workers, but that is the number, 0.2% in this year's budget.
Okay. Obviously, you're familiar with the governor's proposal to increase the minimum wage. There's a lot of non-for-profits and service providers who do not pay that currently. The impact is of great concern financially to a lot of these providers if they can financially sustain that kind of an impact, of course, which is not in the budget whatsoever. Have you talked to the service providers, and has the executive, when they were rolling that proposal out, did they communicate with you on that proposal and the potential impact it would have on mental health providers?
Yes, thank you. We've been working with the executive on those issues. I think that the good thing about the minimum wage is that it will really lift 110,000 families, hopefully, out of poverty. That's critical for mental health as well. I think poverty is one of the biggest traumatic factors in mental health. It will be a gradual process, so that I think will help. But I know there are going to be ongoing discussions about the impact of the minimum wage on various parts of the health system and on our service providers as the budget negotiations go on.
But clinically, it's your position that the increase in the minimum wage will actually improve mental health?
Yes, yes.
Is there any new funding in the budget? I did not see any, but is there any new funding, or will there be any new funding, as some of the appropriations have been outlined, for mental health first aid?
The mental health first aid is being reappropriated into this budget, but there is no new funding for mental health first aid in this budget.
The budget calls for the reduction of 400 beds, Commissioner. Which facilities will see a reduction in beds, and what type of beds will be reduced?
The 400 number was really put in as a way outside number. What we are truly planning on reducing is 200 beds. And which facilities will really depend upon the tracking of the need in various communities. We followed very closely the legislative side letter, and we will not close a bed that isn't 90 days vacant, and 90 days vacant because there hasn't been a need for that bed. So we are looking across the state, some areas where we thought perhaps we could close beds. We haven't, because we have not had 90 days of a bed vacancy. So I wouldn't want to say exactly where. We monitor very closely and then close beds where there is no longer a need.
Okay, two questions to that. So the 400 bed is not accurate. That was put in.
That was put in
to
the
scare
event.
people, or was it?
No, I don't think to scare
Okay.
people. I think it's an outlier number in the event that for some reason it would be possible. But looking at the way our system has been working so far and our ability, it looks like it would probably be really 200, and that's why the allocation for reinvestment is based on the 200 beds.
And when you talked about the 90-day for beds that are closed, and there's not a, in your opinion, or maybe there's metrics to quantify as to why that is. Is it a lack of demand? Is it that the state's not allowing new patients to enter the facility? Is there lack of ability to manage the beds? Is it a staff issue? Why are those beds vacant for 90 days in a lot of cases? Why is there beds going unfilled?
Yeah, they really are vacant because there's not the demand. We watch very carefully if there are individuals who are waiting to come into our facilities, and when we drop those 90 days, there is not a demand and there is not a waiting list.
You are, of course, familiar with Western New York Children's Psychiatric Center.
Yes, yes.
I know you are. I do. Certainly, you know my position. I have been opposed to the proposed closing of Western New York Children's Psychiatric Center. You know, several years ago, more than several years ago, a long time ago, there was clinical reasons as to why a place like Western New York Children's came online.
Right.
Clinically being, there was research, there was studies that had shown that children were better served and had better outcomes when they were served in a separate setting from adult populations or other populations. Has something changed clinically that would justify or warrant or show a benefit to closing Western New York Children's and moving it to an adult campus, BPC?
Yeah. The one study that's referenced is that study was done in the 1960s when state hospitals were very different places on both the adult side and the children's side. And I think when you look at the current literature, what the major emphasis in the current literature is on community-based services and, in fact, on downsizing children's inpatient services. So the goal of the movement of Western Children's to Buffalo is really to free up the dollars to provide what we hope will be upwards. Currently, 500 families are getting more services with our pre-investment. Another 500 families getting community-based services, so that basically we provide those terribly needed community-based services with the savings that will occur because we have moved it onto the Buffalo campus. There are many facilities that children's services can be close to adult services. The quality does not have to be decreased. We are moving the same number of beds. We are moving the same number of staff. We will be monitoring it for the same high level of quality, which we're currently very proud of at Western Children's. So I think it's a win-win situation where we have the opportunity to still provide quality inpatient services, but also significantly infuse community-based services for families and children to help avoid hospitalizations and all the distress that families can feel when their children don't get the services they need.
And the savings that would result from this move what is the dollar value of those savings or projected?
The dollar value total will be $3.5 million, which we are reinvesting into community-based, all of which is going into community-based services.
All going into community-based services in the area currently serviced by Western New York Children's Center?
In Western New York.
A FOIL request sent in 2015 revealed there had been 56 incidences of missing or escaped persons from BPC. What precautions or what stipulations are in place to prevent or certainly protect against elopements with the children moving over to BPC?
The children at BPC, when the children are on the Buffalo campus, they are always under supervision. So there will not be any opportunity for the children to really, we have very low elopement rates from children's services. At BPC, some of those are individuals, when you say 50, include individuals who are in housing on the campus. And a few have been individuals who are in the inpatient service. We have doubled our security at all of our psychiatric centers in terms of how we enter the center, the procedures that are done, because we want to make sure that individuals don't leave until they're ready to leave. And we have also looked at the grounds requirements at all our psychiatric centers. So I think that I could not say that something might never happen, but I think that the number of individuals who have left before they should leave our psychiatric facilities is going to much decrease.
I just wanted to bring attention to, I know there was, when I had spoken to you before, there was the contention was that there was very little public pushback or opposition, or we had seen very little public pushback to this potential closing. I think there were, someone said there were 7 comments in opposition. I have received 6,000 postcards in opposition from people in the Western New York community, which I will gladly deliver to you after this hearing. But I just wanted to, to show you a small sample that there are a lot of folks, obviously, who are very concerned about this move. Some of them are alumni, some of them are families, some of them have been, people that have been serviced. And so I wanted you to have that because I think it's important that you see what folks in the community are saying.
Yeah. Thank you.
And just one last thing, Commissioner, you're familiar with the O'Toole settlement?
Yes.
There's $38 million appropriated this year in this year's budget towards the O'Toole settlement. Where is that money going? How much of that will actually be spent this fiscal year?
Yeah, the O'Toole settlement is the relocation of individuals who are in nursing homes into the community. And there is still a process going on since the settlement to evaluate which individuals can move. I think to date it's been about 170 who have moved. So there's still an evaluation process going on.
170 since when?
Since over the past 2 years or so have moved. And there's still an evaluation process going on, so some of those dollars are placeholders in terms of being able to know exactly the number. For the nursing homes, there was a relatively large group, but that on assessment, I'm working very closely with DOH, which is involved in this. That number has lessened largely because of the medical conditions of the individuals in the nursing homes. So I think it truly is there to make sure that if we need those dollars for this important transition, it will happen. But the process is still being evaluated and in process. So that's why the money is there in the budget.
We don't know actually then how much of that $38 million.
Not yet. We don't know. No, we don't know.
Is there a projected cost of the total relocation of the O'Toole settlement?
Well, that was the projected amount at that point in time.
$38 million.
No, it was going to be, I believe it was broken out between adult home and nursing home, but I think it's close to 12. I'm going to have to get back to you on that, whether it's 12 of the 38 or the full 38. I'll have to get back to you.
Okay. Thank you very much, Commissioner.
Thank you.
Thank you, Senator.
We've been joined by Mr. Avenatti, and next to question, Assemblyman Aubrey.
Good morning, Commissioner. How are you? Noticed in the budget that you are claiming a $2.7 million savings related to the development of specialized units in local jails to restore felony-level defendants to competency. Who ends up paying that cost for them to remain at the county level?
If the felony level competency were at the county level, it would be paid for by the county. Now, currently, let me just explain, but currently they are moving those individuals to the state facilities, and they are paying half of the cost to the state facility. In the state facility, the average cost for restoring to competency is in the range of $120,000 to $140,000. They're paying $70,000 towards that. If they did jail-based restoration, if the county is interested in doing it, it's totally voluntary. Those costs for the county would be reduced by a third. So actually the cost to the county is less, which is why some of the counties might be interested and have suggested they're interested, but it's totally on a voluntary basis if the counties want to do this.
So the projected savings is somewhat speculative.
Well, I actually don't think so, because the individual, they are paying about $70,000 per individual now for these individuals being in our beds, which are very costly, and the length of time they stay. It is true that we are estimating the cost of the jail-based restoration, and that we're estimating at about $40,000 to $44,000. So the difference between that and the 70 would be saved, which is why some of the counties might be interested.
And in the services that are provided through the department in correctional facilities, how important is cultural competency for your staff?
It's very important to have cultural competency for the staff, and I think frankly, I think we need to do even more training. However, with some of the dollars that we got for the violence initiative last year, part of those dollars in training include training in cultural competency for the individuals, both our staff and some of the doc staff who are working with prison population. But we can always use more for that. That's a critical issue.
And is there obviously many of the prisons are far north from metropolitan areas, and the question of how you provide that and how you support that in those far distant places where it may be more difficult to get staff.
What we have to do often if we can't get staff who are of the same culture, or we work with the staff who are not, to have what we call a combination of cultural sensitivity and cultural understanding, so that there are training modules to help people do that. Obviously, the best is to have someone who is of the same culture and of the same background, but unfortunately, we can't have that throughout the system.
And how often do staff get trained or retrained relative to that?
At this point in time, this one we're starting, this training is new, so it was been this year. So I think I can get back to you on how often we're considering the retraining.
Okay. Thank you.
Thank you.
Thank you.
Senator.
Thank you. Our next speaker is Senator John Bonisic.
Okay. Good morning, Commissioner. Thank you for the work that you do. Maybe if you didn't hear me, I wanted to thank you again for the work that you do.
Well, thank you.
I'm here basically to highlight two things that are on my mind. We all have a concern with the growing heroin epidemic, what they're seeing across the country. And yesterday, many constituents came to Albany to lobby. Their number was 50 million for recovery centers in each county. I know we did one in Yonkers for the Mid-Hudson, but I don't see many drug addicts traveling to Yonkers for a continuation of care. So I would suggest to you that this is an area where we probably have to do more of investment to try to help those that are seriously addicted. I'm told by people in the profession that addictions amount to about 8% of our population, and it hasn't changed much. But the point is, when they have addictions, it affects the whole family. I don't have to tell you about it. So that's one thing I want to highlight, if we can do more in that area. And there's an organization in our district called Oasis that works very hard in this area. The second thing I'd like to talk to you about, 3 years ago, Senator Larkin, Mara, and myself provided a $300,000 grant for what we called Research and Recognition Project. It was to help veterans with post-traumatic stress. And with that small amount of money, they treated maybe 27 veterans, and they had a cure rate of 94%. And we got excited about that. And last year we gave them $800,000. So their sampling could be larger. And again, those statistics were similar for the largest sampling of curing veterans with post-traumatic stress. Now, it's pretty much geared to veterans, but it could be a firefighter or a police officer who was involved in a shooting, et cetera, et cetera. Now, this organization has people, naturally, that come from veterans, that are retired military people. And this year, they're coming to try to get $2 million to have larger sampling so they can get the federal government interested in this. For the last 30 years, we treat this problem with counseling and drugs. And now we have a breakthrough process that's being substantiated of cures. And you could say, well, what is this, a miracle? And what they do is they retrain a part of the back of the brain. And it's amazing results. So I don't know how much you know about this project, but I'd like you to become more familiar with it. We're excited about it, and many of us in the Senate are pushing for more money for this successful project. Thank you for being here, Commissioner Sullivan.